Hello, everybody. Welcome to our Graham Rounds. We have a very special speaker today, which I'm pleased to introduce. David Brent, MD, is Academic Chief, Child and Adolescent Psychiatry at the University of Pittsburgh School of Medicine and holds the University of Pittsburgh Medical College Endowed Chair in Suicide Studies. He directs services for teens at risk, a specialty program for depressed, anxious, and suicidal youth. His work has focused on the risk factors for adolescent suicide behavior and depression, and the translation of knowledge about these risk factors into treatment and preventive strategies. His current work has focused on the impact of parental bereavement on mental and physical health of youth, identification of endophenotypes that may explain the familial transmission of suicidal behavior, and the development of innovative interventions for adolescent depression and suicidal behavior. Some of these treatment approaches are described in a recently published book, The Treatment of Depressed and Suicidal Youth, A Clinician's Guide. And today we're going to hear Dr. Brent speak about SSRIs and suicidal behavior, raising the question, cause, and cure. Thank you, Dr. Brent.
Thanks. Is this working now? Yes. Fancy guy. Anyway, it's really good to be here. I really appreciate the invitation because we have family here, both in the department and in graduate school. And what I'd like to talk about today is try to understand the controversy about the relationship between SSRIs and suicidal behavior, which I think has had a huge impact on at least adolescent psychiatry practice. And I can tell you, I was doing a clinical trial when all of this stuff broke. And I think we had to revise our consent form 17 times. Anyway, needless to say, I still have a little PTSD from it. So I don't have any stock or any financial interest related to any pharmacology companies, so I think I can be relatively objective about this. And what I'd like to talk about today is first to address the question, are SSRIs associated with an increased risk for suicidal behavior, and if so, in whom? And if you look at the pharmacoepidemiologic studies, they differ from those in clinical trials, so what can we learn from that? And then finally, what can we do clinically to reduce suicidal risk in depressed patients, given that you have this issue in the background? So just some definition of terms. What we mean by a suicidal event is a new or increased amount of suicidal ideation or an actual attempt. Suicide attempt we define as self-destructive behavior with explicit or implied intent to die. Non-suicidal self-injury, probably don't need to define that around here, but it's self-destructive behavior where the motivation is to modify mood or social behavior but not to die. And a serious adverse event is more of a clinical trial term, but it is an event that results in either hospitalization, disability, impairment, or, in the worst case, death. So as to the first question, this is a meta-analysis that was conducted by individuals from the FDA, looking at the odds ratios of suicidal events, which, again, is either an increase in ideation or actual behavior, across the lifespan. And what you can see is that there's an inverse relationship between the risk of suicidal events and age. And as a matter of fact, in the older group, even in the clinical trials, the use of SSRIs, which is what most of these trials are, seems to be protective, but in the younger groups, there seems to be an increase in suicidal events. And it's important to remember that when you talk about the odds ratio, people say it's a threefold increase. You're talking about like 1.2% versus 0.4%. So that the odds ratios are indeed high, but the absolute risk difference is very low. So why would you see a risk for suicidal events just in the young? Well, one thing is, if you look at the epidemiology of suicidal behavior, the peak incidences in the young, although that wouldn't necessarily explain why you would see more in people exposed to drug versus control. We do know, though, that the components of suicidal behavior are different in different age groups. And there is an inverse relationship between the age of suicide and the amount of contribution of impulsive aggression as compared to anxiety and affective disorders, which in the lower quadrant you could see that increases as a proportion of the contributor to suicide in age. And in geriatric populations, suicide is almost completely explained by mood disorders, whereas that's not true in the younger group. So therefore, it's possible that they would respond differently to an antidepressant treatment. We also know there's some biological differences between younger and older people. And if you look at the relationship between some of the serotonin receptors and treatment response, this is done in adults, that people who do not respond to antidepressants have a greater density of 5-HT1A receptors. And interestingly, there's an inverse relationship between the density of these receptors and age. So therefore, it's possible that in younger people, they're going to respond differently to antidepressants. We also know there's a relationship between the 5-HT2A receptor, the density. These are in, I think these are in postmortem samples, and impulsive aggression. And what you can see is there's an inverse relationship between the density of these receptors and age. So therefore, there are some biological differences in younger people which could predispose to more suicidal events. Then some people say, well, maybe the drugs just aren't as effective in younger kids. And in fact, if you look at the risk difference, meaning the rate of response in drug versus placebo, in children it's very low. Even in adolescents it's pretty low, except for the studies that have used fluoxetine. So maybe the drugs just don't work as well as they do in adults. However, it seems like the main culprit is that the kids who tend to be impaneled in clinical trials aren't very severe. And if you look, as the kids get more severe, you go along the x-axis, you can see that drug and placebo separate quite nicely. And it so happens that the studies that used fluoxetine were the ones that were done at academic medical centers where they were more restrictive in who they took. And one of the things that this meta-analysis showed is that there's an inverse relationship between the number of sites in a study and the placebo response rate. So if you have a study with 100 sites where they're in a hurry to enroll, they tend not to be that selective, and consequently, you really can't draw inferences about how the drug works in truly depressed people. Another issue is that kids metabolize antidepressants differently than adults. And for example, in the half-life of citalopram is almost half what it is in adults. Yet the drug studies are using the same dosing. So maybe we're underdosing these kids. And in fact, in the Tordia study, we were able to show that there's a better response rate in kids who had a higher drug concentration than in kids who had a lower drug concentration, whereas in adults, the report is that there's no response rate. So we may be underdosing these kids. And then finally, people say that maybe kids are less adherent, and consequently, you're not getting a good effect. And so this again comes in the Tordia study, And we just, asked the kids to bring back their medication and did a pill count and inferred, how much they were adherent to their medication. And there's a nice step function between adherence and response. So it's, again, this is a possible explanator. Finally, kids who have early onset depression are at increased risk for bipolar disorder. And this pharmacoepidemiologic study shows that basically the earlier the onset of depression in kids who were exposed to antidepressants, the higher the risk of mania. And in the Tortious study, we took a look at this and we divided the kids into 3 trajectories of depression response. And the top one is the worst. They started very high and didn't respond very well. And on the bottom, this is the more ideal response rate. And we did find higher numbers of bipolar symptoms in the kids who had a poorer response rate. However, we haven't published this because they're not clinically significant, and we just really don't know what to do with this. But part of it is maybe our threshold for what's clinically significant is too high. But based on the way we're practicing psychiatry today, we do have a statistically significant difference, but I don't know if it's clinically significant. So, to answer the question of why are SSRI-related events a phenomena of youth, one possibility, suicidality more common, but then you should see an equal increase in drug and placebo. There may be some developmental neurobiological differences. Perhaps the SSRIs are less effective. That's not consistent with the data, although it may be that they're not used as effectively. There may be issues of poorer adherence and shorter half-lives. However, there are increased rates of suicidal events in kids treated with fluoxetine that has a half-life of 5 days, so that wouldn't necessarily explain that. And as far as the subsyndromal bipolar disorder, maybe. So then, now that we know the age group, can we hone in and find out who's really at risk for suicidal events? So one risk factor is a poor response to antidepressant treatment, or psychotherapy for that matter. This again comes from the Tortious study. There are similar results in TADS. The red represents the kids with serious adverse suicidal events. The purple is any adverse event, and then the blue is no events. And basically you see a step function. The kids who had the most serious events started at very high suicidal ideation, higher depression, and even though they had some response, by the end of the treatment they were still in the risk zone for having a suicidal event. So, unless we can accelerate the treatment, this group is going to be at risk. And in fact, in the adult pharmacogenetic studies, all of them report poor responses associated with suicidal events. In addition, not surprisingly, high ideation, family conflict, drug and alcohol use. This is not abuse, but just any use was contributory. And there are some reports that SNRIs, like Effexor, convey a higher risk for suicidal events than other drugs. Although the confidence intervals here overlap, the highest signal is in the SNRI group. And in our study, we found that in kids who had high baseline ideation, that in the venlafaxine-treated group, they had a higher rate of self-harm events. And we also found over time, although it wasn't a huge difference, that that the kids treated with venlafaxine had higher self-reported suicidal ideation over the course of the study. And one other thing we didn't expect is that the kids who were treated with benzodiazepines, they were treated clinically. They weren't assigned randomly, had much higher rates of events, and this was even after you adjusted for baseline differences. So there have been some other reports of associations with hypnotics and so on with suicidal behavior. So, this may be something that we need to consider much more carefully. So in whom do suicidal events occur? In younger people, in those who are unresponsive to antidepressant treatment, those with high ideation, drug and alcohol use, family conflict, and perhaps, the use of benzodiazepines and SNRIs. So then, how do you resolve the difference between what are the conclusions of pharmacoepidemiologic studies and the clinical trials? And finally, what has been the impact of the black box warning on clinical practice and suicide outcome? So this looks at the sales of SSRIs. It involves a whole bunch of different countries. And basically you see an inverse relationship between the sales of SSRIs and the suicide rate. And this slope is the highest, it's the sharpest decline in the 15 to 24 age group, the same age group that we're saying is the only one that's at risk for these suicidal events. This is a study from Sweden that showed a steepening of the decline in the suicide rate after the introduction of SSRIs. Tricyclics, they're much easier to overdose on and kill yourself than SSRIs. And this is a study from Robert Gibbons looking at suicide rates related to antidepressant use. I think he looked at the county level so that he had like hundreds of replications of these relationships. And basically, the more tricyclics you were prescribing, the higher the suicide rate, and the more SSRIs related to tricyclics, the lower the suicide rate. And in this slide, it just demonstrates an inverse relationship between prescriptions of fluoxetine and of suicide rates. And I couldn't resist this slide. This, of course, is a study done in Seattle by Greg Simon. And what he showed is that the peak incidence of the use of SSRIs, antidepressants, mostly SSRIs, in adolescence is immediately after a suicide attempt. So if you take pharmacoepidemiologic studies that show an association between suicidal behavior and SSRI use, and they don't have good temporal resolution, then you're going to end up showing an association between drug use and suicide attempt when it's really the other way around. The other thing that this tells you is that the kids who are in clinical trials, who are mostly excluded if they've made a recent suicide attempt, and the kids who are getting SSRIs in the community are two different populations, and that regardless of how you interpret the studies that were in the FDA meta-analysis, those aren't the kids that are being treated with SSRIs in the community. So it's an unfortunate experience, but the black box warning does offer a natural experiment. For those of you is there anybody here that doesn't know what that is? Okay. What happened was there was a report originally from England that there was an increased signal of suicidal events in drug versus placebo in kids treated with paroxetine. And this triggered a wider look at antidepressants, placebo-controlled antidepressant trials, and subsequently the FDA did what's known as a black box warning, because it's the warning in a black box, and saying that use of antidepressants could increase the risk for suicidal events. What happened in the newspapers is it says it's associated with suicide, even though there were 4,300 kids, no suicides. But that was the message that people got. This comes from work by Ann Libby, and what she showed is subsequent to the black box warning, not only was there a decline in antidepressant use, there was a decline in the diagnosis of adolescent depression, because people are faced with a terrible dilemma. The treatment that they can use in primary care is SSRIs. They were passing it out like water. All of a sudden, it's dangerous, they can't use it. So why diagnose depression? And there was not a compensatory increase in referral for psychotherapy. So this is not good. This comes from work by Jeff Bridge, showing that there was a bump in the suicide rate in adolescents after a long period of decline. subsequent to the black box warning. And Robert Gibbons showed the same thing. The same thing occurred in the Netherlands. So, the conclusions we can draw from these studies, I don't think I can say pharmacoepidemiology again, is that the greater the use of SSRIs, the lower the suicide rate, both within defined geographic areas and also over time, that SSRIs are more protective than tricyclics, that the effects are found even in the 15 to 24 age group. And I should add that a suicide attempt is actually the signal event that initiates the use of SSRIs in clinical practice. So why are these results so different? So first of all, there's a difference in size. You're talking about hundreds of thousands of people in these studies versus the clinical trials all told have 4,300 kids. There's also a difference in the period of observation. The period of observation in the clinical trials is 8 to 12 weeks. Here, the period of observation is much longer. There's the issue of control and causal inference. Clearly, the clinical trials, you have better control. But the kids who are in the clinical trials are not the kids who are getting antidepressants. And finally, that the outcomes are different. In the pharmacoepidemiologic studies, they're looking at completed suicide. They're looking at suicide attempts. In the clinical trials, they're looking at suicidal events, which are mostly increases in ideation, very few attempts, and no completions. So then the question is, are these the same or not? So we can look at both sides of this. You could make the argument that treatment studies that closely monitor patients may catch individuals who are suicidal prior to their making an attempt, in which case having the definition of suicidal events is a good thing. You know, it makes sense because you would actually have fewer attempts because of that. And there have been some studies that have shown similarity between people that have suicidal events and those that actually make attempts. And however, I think there's a bulk of the argument is in the other direction. These are modest increases in suicidal ideation. They correlate with poor response to treatment, and also there are an abundance of studies showing that people with suicidal ideation and people who actually make attempts are two different populations. And I had to do a review of the pharmacogenomic studies of predicting suicidal behavior. This was an interesting experience because there were only 6 studies. They asked me to do it. I did it, and then one of the reviewers said, "Do we really need a review with only 6 studies?" And I said, "It's a really good question. I think you should ask the editor." In any case, having done it, what I found, there were 461 events across these studies. Almost 100% of them involved an increase in ideation rather than behavior. The STAR-D study, I think, are the best known and quite frankly the best analyzed data. But a one-time increase in suicidal ideation from none to wondering if life is worth living, that's a suicidal event. And that past suicide attempt was related to a suicidal event in only 1 out of the 6 studies, suggesting they're 2 different populations. In addition, there are family genetic studies showing that people with suicidal ideation and people that make attempts are different. This is a very elegant study that looked at mothers with depression, some of whom had suicidal ideation but never had attempted, some of whom had an attempt, and some of whom had neither. And there was an excess in suicide attempts in the kids only of the suicide attempters, not of the suicide ideators. They had an equivalent rate. So that suicidal ideation is related to depression. The propensity to act on a suicidal ideation is another trait. And we also demonstrated that in a similar type of family study. This looks like the Palestinian flag, which is a good thing. Anyway, the black represents those with the highest loading for family history of suicidal behavior. The red is only one relative with a suicide attempt, and the green is no relatives with a suicide attempt. All of the offspring are offspring of people with a mood disorder. And what you can see is the high family loading, not only did they have an increased risk for a suicide attempt, but on average the attempts were 8 years earlier than they were in the other group. And there was only one trait that mediated the familial transmission of suicidal behavior, and it was not depression. It was impulsive aggression. So it's a different trait that's being looked at, and it's one that's not being targeted by antidepressants, although I suppose it's possible that in these kids it makes that particular trait worse. So the clinical implications of this are that the treatment of depression, it may be necessary, but it's not sufficient to reduce suicidal risk. And in the young, for whom impulsive aggression is a larger component of early onset depression and suicidal behavior, that also needs to be targeted if we're going to be successful in reducing suicidal behavior. So then, what about the argument that SSRIs are actually protective? This comes from the same FDA study. It's just a graphical demonstration. You can see after the age of 40, even in these clinical trials, the medication versus placebo is protective against events, at least. But even in adolescents and kids, this comes from a meta-analysis that Jeff Bridge did, and what you can see is that this is the difference in suicidal events between drug and placebo, pretty small, and then this is the difference in the response rate. The number needed to treat are the number that you need to treat in order to get a true response. It's about 10, not great, but it's significant. The number needed to harm is about 120. You have to treat 120 people in order to get one suicidal event that's not explained by chance alone. The ratio of the two is about 11 to 1. And we wrote this paper because you can't talk about risk without talking about benefit. And so you have to consider that for every that there's a suicidal event, for every suicidal event there are 11 kids who are going to benefit from the drug. And every family has to decide on them by themselves if that's an acceptable risk-benefit ratio or not. But it leads to a much more rational discussion than the hysteria that we've been confronted with before. The Gotland Study is a study that trained primary practitioners in an island off of the coast of Sweden in recognition and treatment of depression, and they were able to show a decline in the suicide rate subsequent to the intervention. And so if you look in aggregate, it seems that that antidepressant treatment does protect against suicidal behavior, and it may be true even in the young, but it may not be as true in the young as in the older, where the contribution of depression to suicidal risk it becomes an increasing proportion of the attributable risk. So, given that, how do we deal with this? So, first of all, the clinical implications of the black box warning. I think the main public health problem about suicidal events is that it scares people away from treatment. That's the biggest public health impact of the black box warning. You can see a decline in the rate of diagnosis, and obviously then there's a decline in the rate of treatment. The risk-benefit ratio is pretty high, even so. The risk difference in our meta-analysis was less than 1%. Yes, the rate was almost twice as high, and depending on how you want to skew the conversation, you can scare people. But that 0.9% difference is not very big. And most of these events are modest increases in ideation, not really clinically significant. So how do we reduce the risk of suicidal events? It seems that what we need to do is accelerate treatment response. And there's evidence that combination treatment, psychotherapy plus medication, accelerates treatment response. You want to optimize drug level through promoting adherence and perhaps monitoring levels. It would be better to use an SSRI than venlafaxine. Some of these risk factors for suicidal events, it would seem logical that you would want to address. And finally, we need, through either psychotherapy or medication, we need to help kids to regulate impulsive aggression. I know this is a good setup for the new study that's going to start here on DBT. But just to mention, there is some evidence, at least in some populations, use of mood stabilizers is protective against suicidal behavior. In lithium, which I think it's very difficult to get kids to take. There's evidence in schizophrenia that clozapine is more protective against suicidal events and suicide attempts than olanzapine, which is a good treatment for schizophrenia. And there's some evidence that augmentation of SSRIs in resistant depression with an antipsychotic can reduce depression and suicidality. And in one study, it was also shown to decrease impulsivity. It may also decrease spontaneity, but that's another story. And so, the question is whether we should be considering using this in adolescents, of course, without, in some subgroup who are chronically suicidal and who aren't responding to antidepressants alone. So to summarize, are antidepressants associated with suicidal events? Yes. In people under the age of 25, the risk difference around 1 to 2%, lower in adolescents. Why are youth more prone to suicidal events? We don't really know. Probably some neurobiological differences. There's differences in drug metabolism, possibly a greater risk for mania. The clinical significance, it's low. Most suicidal events are very modest changes in the level of suicidal ideation. The biggest problem is that it's led to treatment avoidance. In whom are they most likely to occur? Kids with early onset depression, poor response, high baseline ideation, drug and alcohol use. This is below subsyndromal. Even occasional use in our studies, at least, was associated with poorer treatment outcome and higher risk for suicidal events, and perhaps use of benzodiazepines. The question: do antidepressants protect against suicide? The pharmacoepidemiologic studies seem to indicate that there is protection. It may be a stronger effect in older adults. This leaves us with a number of research questions. First of all, even given the questionable clinical significance, why is this happening? Why is this happening in younger people? And what can we learn about the nature of depression and for that matter, about developmental neurobiology? How can we better identify people who are really at risk? And I think this is the million-dollar question. What can we do to increase the pace of antidepressant response? 40% of suicidal events occur within the first 3 weeks of treatment. And, we tell people that they're not going to feel anything for 4 weeks. So there's a mismatch between the window of risk for suicidal events and what we have to offer. And then what additional pharmacological or psychosocial interventions can reduce risk? And these are some of the questions that I hope to apply myself, and I'd like to see the answers to in the relatively near future. Thank you very much. So wait a minute, I'm supposed to do something here. Okay. Are there questions?
David?
Yes.
It was really wonderful and very illuminating. I'm intrigued by your comment about the association of benzodiazepines in your studies and the associated increased events. You commented that this was not a randomized application, but in fact a clinically driven one. Does that suggest that these individuals who likely got benzos were more agitated or more anxious, otherwise perhaps representing a subgroup who might, for those reasons, have been at risk?
Yes. So the question is the association between benzodiazepines and suicidal events in our study. That the medications were given for clinical need, not randomly. And in fact, the kids who got benzos had higher suicidal ideation, greater depression, I think greater anxiety. When we controlled for those factors, there was still a strong association, but you can only go so far with statistics. What I would say is there now are some other studies that are emerging, like Marcia Fallenstein, I think, looked at a large cohort of veterans and showed an association with hypnotic use and suicide and suicidal behavior. I think this merits a closer look. But in fact, when we published this, I just mentioned it, in the results and in the discussion, and the editor wanted us to put it in the abstract. So I put it in the abstract, and then I said it was an N of 10, so that anybody who was reading it would know that I wasn't claiming causality, although somebody still wrote in about that. So I just think it's possibly a signal, and I think we need to be much more thoughtful about the use of these agents.
Even, for example, disinhibition of the aggressive, impulsive sort of behavior would be another mechanism.
Right, and the laboratory tests of the impact of these medications would be consistent with that.
Does Alan Kasdan's work with kids who have both externalizing and internalizing disorders and his interventions seem to have any effect on reducing that mechanism, that aggression, impulsivity mechanism that might lead to more suicide attempts?
I think I understand the question. It's Alan Kasdan's intervention.
Yeah, with kids who have internalizing and externalizing disorders. Is it effective in reducing the impulsivity that may lead to suicide attempts? Right. Has there been has he done work on that?
Not to my knowledge, but Nancy and I worked on the unit where those things were first developed, I don't know how many years ago. But it makes sense that it should have an effect. But to my knowledge, it's not been evaluated. The one study that I've seen that targets that to some extent is something that Shep Kellum did, where they did some kind of a classroom-based intervention in public schools in Baltimore with kids who were heading towards conduct disorder and teaching, problem solving and negotiation and things like that. And they did demonstrate a decreased risk of suicide attempt on follow-up. Yes?
Yeah, you mentioned half-life differs in kids compared to adults, and you mentioned that it would be more difficult to achieve the therapeutic blood level. Another possibility is that it might cause more fluctuation in blood levels over time, and that combined with the non-adherence could put some kids in some SSRI withdrawal. Now, you mentioned that fluoxetine is also implicated. And so my question is there any relationship between the half-life of the SSRIs and the suicidal events?
Yes. Okay, the question is the relationship between the half-life of the SSRI and suicidal events, because the shorter half-life drugs the kids, if they're not adherent, might be more vulnerable to withdrawal effects. It's an idea that makes a lot of sense. We were not able to find a relationship, but the study wasn't designed to do that. It still makes sense, but it doesn't explain why you see it with fluoxetine, where they wouldn't be experiencing withdrawal. Yes?
I'm thinking to that slide you showed from, I think, the LEAP study with the children of mothers who had a suicide attempt having an earlier onset of suicidal actions. Does this become a valuable screening question, or does it lose its predictive quality? Is it something that could help you to identify high-risk individuals?
Okay. That's a very good question. So the question is, given the family genetic studies showing that suicidal behavior runs in families, how useful is a family history for suicidal behavior to identifying people at high risk? I gave a talk to the residents earlier today, child psych residents, and that we need to differentiate between risk for imminent suicide, the proximal risk factors, and distal. Family history is a distal risk factor. So when you're clinically evaluating somebody, you're more worried about, are they at risk for suicide now, or in the next 24 hours? And family history is one of those that doesn't, it's not something that's imminent. So the way, though, that I do think it could be useful is, I think an Olds-like study with families where there's a parent with a mood disorder and a suicide attempt, I think those families should be targeted with a study that focuses on very early intervention. But I think that clinically, it's important to ask, but in general, it doesn't help you that much, even though I've spent a lot of time studying it. It doesn't help you that much to know what to do right now. Does that make sense? Yeah. Yes.
For the clozapine study you talked about, it may be that it's the frequency of visits the person has rather than the clozapine that results in those schizophrenic individuals having lower risk. If that hypothesis is true, would that potentially also be an issue for children? They had more visits, they'd be less likely to have suicidal events.
Okay, so the question is, to what extent is the relationship between suicidal events and treatment related to the fact that people who are getting treatment may have more, a particular treatment, may have more visits? Well, I'll be honest with you, it's been a long time since I've carefully read the Intercept study, the one that looked at clozapine, and I don't know the answer to that. It certainly should be looked at. And people have hypothesized that that's an issue in the FDA studies. But in the TAD study, they also found a signal, and I think they controlled for patient contact pretty well. And in fact, the people that got medication only had less contact than some of the other individuals. I will say that in our trial, we did have a trend towards higher non-suicidal self-injury in the kids who got combination treatment. And either our treatment was not very good, or there was more contact and more attention to it. And so I think your point is a valid one. I'm not sure how strong and explanatory it is in these particular cases. No question. Oh, sorry.
Any difference in personality traits between patients who try suicide and those who don't?
Are there differences in personality traits between those who try suicide and those who don't? Well, most of these studies didn't measure that. But if you look at a whole range of psychological autopsy studies, comparing suicides to controls, or prospective studies of suicide attempts, personality disorder is a potent risk factor for suicidal behavior, particularly antisocial disorder and borderline personality disorder. The risk, borderline personality disorder is when people call them manipulative, I think they have a 10% mortality from completed suicide over their lifetime. Thank you very much.